USMLE, understanding the clinical anatomy of the heart, is high yield, especially in relation to imaging, common pathologies, and anatomical relationships. Here's a breakdown of the most important points. Eyes, surface anatomy and chambers. 1. Heart borders and surfaces, chest X-ray and CT relevance. Right border, right atrium, RA, left border, left ventricle, LV, and left atrial appendage. Inferior border, right ventricle, RV, and part of LV. Anterior surface, mostly RV, important for trauma, pericardial effusion. Posterior surface, base of the heart, left atrium, LA. Clinical correlation, LA enlargement can compress the esophagus, causing dysphagia, seen in mitral stenosis. Imaging correlation, best seen on lateral chest X-ray or echocardiogram. 2. Chamber-specific clinical relevance. Right atrium receives blood from SVC, IVC, coronary sinus. Pathology, atrial flutter, sawtooth waves on ECG from reentry circuits. Right ventricle forms most of the anterior heart. Pathology, RV infarction, inferior MI, hypotension plus JVD plus clear lungs. Left atrium, posterior heart, most common site for atrial fibrillation, AFib, due to pulmonary vein openings. Pathology, AFib thrombi and LA appendage, stroke risk. Left ventricle, thickest myocardium, pumps against high systemic pressure. Pathology, LV hypertrophy, LVH from HTN, aortic stenosis. 2. Coronary circulation, high yield for MI. 1. Arterial supply, coronary dominance is key. Right coronary artery, RCA, SA node, 60% of cases. AV node via PDA in right dominant circulation. Inferior heart, RV, part of LV. Pathology, inferior MI, bradycardia, AV node ischemia. Left main coronary artery, LMCA, divides into left anterior descending, LAC, most common artery for MI. Supplies anterior LV, anterior septum, apex. Pathology, anterior MI, ventricular septal rupture, VSR. Left circumflex, LCX, supplies lateral LV. In left dominant circulation, gives PDA. Posterior descending artery, PDA. Right dominant circulation, 85% from RCA. Left dominant circulation, 5% from LCX. Codominant, 5% from both. Pathology, posterior MI, rare, seen on ST depression in V1, V3, tall R waves. 2. Venous drainage, great cardiac vein follows LAD. Middle cardiac vein follows PDA. Small cardiac vein follows RCA. Coronary sinus, main venous drainage into RA. 3. Conduction system and arrhythmias. SA node, 60 to 100 BPM, supplied by RCA. Pathology, SA node dysfunction, 6 sinus syndrome, bradycardia. AV node, 40 to 60 BPM, located at interatrial septum near tricuspid valve, supplied by RCA and right dominant hology. RCA infarct, AV block, bradycardia, long PR interval. Bundle of His and Purkinje fibers, 20 to 40 BPM. Pathology, damage, wide QRS, bundle branch blocks, VFib and MI. Valves and clinical correlations. 1. Mitral valve, most commonly diseased. Mitral stenosis, rheumatic fever, LA dilation, AFib, dysphagia, mitral regurgitation, MVP, ischemia, endocarditis, holosystolic murmur. 2. Aortic valve, aortic stenosis, systolic murmur, crescendo-decrescendo radiates to carotids. Aortic regurgitation, diastolic murmurs, widened pulse pressure, bounding pulses. 3. Tricuspid valve, tricuspid regurgitation, IV drug users, endocarditis. Tricuspid stenosis, carcinoid syndrome. 4. Pulmonic valve, pulmonary stenosis, congenital heart defects, e.g. HOF. Pulmonary regurgitation, post-repair of TOF. V. Pericardium and clinical significance, fibrous pericardium, non-stretchy pericardial tamponade risk, serous pericardium, parietal and visceral layers, pericardial effusion tamponade, Beck's triad. Hypotension, JVD, plus muffled heart sounds. Pulsus paradoxus, SBP drops 10 mmHg with inspiration. ECG finding, electrical alternans. Pericarditis. Causes, viral, uremia, autoimmune, SLE. ECG, diffuse ST elevations. Pain relieved by sitting forward. Fetal circulation, USMLE loves this. Ductus arteriosus becomes ligamentum arteriosum, closes after birth. PDA treated with indomethacin. Foramen ovale becomes fossa ovalis. If patent, paradoxical embolism, cryptogenic stroke in young adults. Ductus venosus shunts blood from umbilical vein to IVC, bypassing liver. 7. Imaging correlations, chest X-ray, CXR, boot-shaped heart, tetralogy of Fallot, water bottle heart, pericardial effusion, figure 3 sign, coarctation of aorta, echocardiogram, best for function and valvular disease, cardiac MRI CT for congenital defects, tumors, pericardial disease. Fact 8. Clinical cases, USMLE style questions. 1. 66YO male with chest pain radiating to left arm, ST elevation in leads V2, V4. DX, anterior STEMI, LA infarct. 2. SHA, 36YO IV drug user with holosystolic murmur louder with inspiration. DX, tricuspid regurgitation, endocarditis. 3. 45YO with dysphagia and history of rheumatic fever. DX, LA enlargement from mitral stenosis compressing esophagus. This covers the most high-yield heart anatomy topics for USMLE Step 1 and Step 2. Let me know if you need mnemonics, diagrams, or extra details.